you, Dr. Walsh. We've finally come to the bottom of this panel, quite literally, as we move forward with anorectal diseases, Hirschsprung's disease, and anorectal malformations. As you may remember, Hirschsprung's disease affects about 1 in 5,000 to 6,000 children. It's a problem of congenital aganglionosis that's usually diagnosed and treated in infancy or young childhood, and treated surgically via one of these 3 procedures. The Swenson procedure on the left, where the entire aganglionic colon has been removed. The Duhamel is pictured in the middle, where the aganglionic portion of colon is removed down to the level of the rectum, and the healthy colon is brought in an end-to-side anastomosis fashion to half of the rectum, where it's brought down retrorectally. And you have an anterior wall that's aganglionic, and then your posterior that has healthy ganglion tissue there, usually to create a reservoir. And then the Suave procedure, pictured here, letter C, where this aganglionic section has had a mucosal and submucosal resection done. These can be done in an open fashion, and nowadays many are done as a transanal approach. Traditionally, we've been taught that outcomes in childhood really resolve generally by school age, and that by adolescence and adulthood, these patients do not have ongoing complications. But more recent studies in the last 20 years have shown that really there are ongoing issues that these children suffer well into adolescence and adulthood. And these studies have shown that only about 50% of adolescents have an optimal outcome, and many still suffer from either impaired continence or constipation. Further studies have shown that these problems continue into adulthood and really do not get any better once they've reached sort of this outcomes they have at the age of adolescence. Again, with only roughly half of adult patients having optimal outcomes, and still many suffering from incontinence and constipation. A recent study out of Finland looked at 92 patients who were a mean age of 43, and they looked at their overall bowel function score, which is a combination of the ability to hold back defecation, to feel the urge, the frequency of defecation, soiling, accidents, and overall bowel function scores compared to a control group were lower, and only a half of them had a normal bowel function score. And you can see that soiling, accidents, and constipation were significant issues for these adults. In addition to looking at their bowel function score, they looked at a quality of life index to see how are these scores having an effect on their overall quality of life. And surprisingly, although the quality of life score is in general lower here, it's really, the mean difference was only slightly lower, just barely reaching statistical significance. When they looked at the specific areas that were worse, their frustration with illness, harm to their sexual life, and loss of physical strength due to illness were the areas specifically in quality of life that were mentioned. However, they had areas of quality of life compared to healthy controls that were better, such as the ability to participate in leisure activities and a better ability to sleep. But overall, 20% of them had a very low score, indicating a clearly decreased quality of life. A study out of the Netherlands followed up on this and looked at quality of life in patients who had both Hirschsprung's disease and anorectal malformation. And they found similar findings, that there were lower scores than healthy controlled peers in physical functioning, physical role functioning, and general health. Overall, the scores were lower for patients who had anorectal malformations than for Hirschsprung's disease, and the scores for the patients with Hirschsprung's disease were lower in the physical health area. They also found, by doing a follow-up study 3 years later, that the degree of impairment of bowel function seemed to get worse as patients got older. So this was a relatively new finding. Previous studies having looked at bowel function at adolescence and then again at adulthood, but then it appears that after a certain period in adulthood, the degree of bowel impairment worsens again. Surprisingly, in looking at what factors affected their quality of life scores, it was not disease-specific functions such as soiling or incontinence and constipation, but it was overall psychosocial functioning that seemed to really impact their quality of life. So how do adult practitioners or pediatric surgeons taking care of the older children and maybe young adults who are not doing well after Hirschsprung's disease, and anorectal malformations, how do we approach these patients? So I'll go over some algorithms to approach the main problems in these patients, which are soiling and constipation and the complications associated with that. So the first question with patients who are soiling is, do they have intact sphincters? And really the way to evaluate that is going to be an exam under anesthesia. So in these pictures, you can see in picture A, a normal anal exam with normal dentate line. In picture B, though, the anastomosis has been done too close to the skin level and there is no dentate line, so there's a loss of any anal canal. Picture C shows an open anus. This is under anesthesia that's likely due from excessive stretching at the time of surgery. And on picture D, you see that open patulous anus in an awake child. Picture E, you can see on the right side, you have a clear dentate line there, but the dentate line is missing from the left side. So they only have half an anal canal there, which is really important for sensation. And then picture F, a clear example of severe excoriation from continual soiling due to that open anal canal. Once the sphincters are evaluated, the question is the bowel hypermotil or hypomotil? So is there any time for things to move through, or is there a tendency to just loose stool? And this can be evaluated by contrast enema, where you can see in a very overfull colon from constipation, and picture B, a normal contrast enema. So when there's constipation with excessive stool burden and hypomotility, which can lead to the pseudo-incontinence Dr. Hannah mentioned and leaking due to overflow incontinence, the issue becomes using large enemas and a bowel management program that uses large enemas. For patients who are hypermotil or have a tendency to loose stool, the bowel management program may include small enemas or may just use constipating diets, bulking agents, loperamide to keep things from moving through so quickly. So what about the other half of the algorithm, those who are more constipated, have distension? Well, persistent obstructive symptoms also have to be examined, and the first step is a physical exam. And if there's no stricture, then the next step would be a rectal biopsy. Is there an area of aganglionic colon that's been left in place? Newer studies show that while there used to be thought that there was an area of aganglionic colon and then a pretty sharp transition to normal colon, that aganglionic section may actually have a much longer gradual transition to normal colon. And so while some of us were trained to take only a few centimeters above an area with ganglion cells, it may actually be a much longer segment of 10 to 15 centimeters where there's not normal ganglion tissue, and so an area may have been left in place that is not fully ganglionated. Additionally, there's some thoughts of a process of deganglionation, so to speak, that it may be acquired area of aganglionic section after a pull-through is done. So if there's no stricture but persistent obstructive symptoms and a patient has not had a rectal biopsy, that's an important part to do, because if there are no ganglion cells there or atypical ganglion cells, they may need a redo pull-through to remove that aganglionic section. If there are ganglion cells present, then a motility workup can be done through anorectal manometry. If it's normal, sometimes Botox can be done in order to release the sphincter there. And if there's a clinical response, that often needs to be repeated depending on how the patient does after the procedure. Abnormal foci from motility, if they're short, may need to be resected. If there's a long section, then it may need a bowel regimen or potentially a stoma. And a stricture obviously needs to be addressed. If you find a stricture on examination, then that can sometimes be addressed through dilations and other times through a redo pull-through. Anorectal malformations, patients with anorectal malformations often have similar long-term postoperative problems. The patients with low anorectal malformations, such as the one up top where you have a perineal fistula or a fistula to the lower segment of the urethra, these patients usually have good outcomes or better outcomes because they usually have normal musculature and normal innervation to their musculature. The patients with high malformations are the patients who really have the more complications in terms of postoperatively after their pull-through procedures. And the outcomes in high malformations really are not very good, with less than half having good outcomes in long-term follow-up series. And in many of these series, patients have had to have some kind of redo operation in order to have even fair outcomes. The study by Rintala, as well as the one by Hassink, almost half of them had sphincter repairs done at some point to try and improve their outcomes. Newer studies have looked at PSARP, which is the procedure that probably most pediatric surgeons doing the procedure now do, but there's not a lot of long-term data on yet. And the outcomes for that do tend to be better based on this most recent study. However, there are often these patients suffer from incontinence again, and this is a very nice enema picture of what Dr. Hanna was describing of overflow incontinence. You can see in that contrast enema on the right, there's a huge stool burden, and that's very easy to see how that could lead to an overflow incontinence situation. These patients need an aggressive bowel regimen, and centers that do a lot of these have a very nice setup for it. The rest of us have to make our own setup for it, but they really need an aggressive bowel regimen, and it takes a while to figure out the exact program that's going to work for the patient. Recommended management is either through admitting or if you're in a system where you can do it as an outpatient, you start with an enema volume, and it depends on your contrast enema whether you're going to go with a large volume enema if you have a huge stool burden like on the right, or a smaller volume if you have a somewhat normal enema. But you give that volume of enema, and the following day you do an x-ray and see what the stool burden is like. At the same time, you have the patient or the patient's parent, if they're still a child, record how often are they going, what is their soiling like during the day. The goal is to get them to be socially continent or clean during the day, or clean as long as a period of time as you can, even ideally for a full 24 hours, so that they are having an enema, evacuating their colon via their enema, and then not needing to evacuate again until the next day and the next enema with no soiling in between. So in this picture, picture A is after the first enema on day 1. The patient still had soiling, and you can see a large volume of stool still there. So the volume of the enema and the concentration was increased. The following day, they still had some soiling. The KUB again shows some stool in the descending colon, though less than the day before. So they increased volume again, and on day 3, they went 24 hours with no soilage, and the KUB with no stool burden left in the colon. That then is repeated to make sure that that volume works, and if that's the volume that works, that then contributes to the determination of what you're going to use for something like the Malone antegrade colonic enema, as described by Dr. Hanna. But these patients often need some sort of defined enema program in order to keep their colon clean, their colon empty, and themselves clean for 24 hours. There have been trials of this procedure, dynamic gracilloplasty, for patients with severe incontinence, where the gracilis muscle is flapped down to try to recreate a sphincter with some electrode stimulation there. Unfortunately, the outcomes in patients with anorectal malformations are not very good. This pie graph shows various levels of continent, and grades 1 and 2 would be considered good outcomes, where they're either completely continent, and there are none who were in this study, or incontinent only to flatus, which only 35% of them had a good outcome by that definition. Grades 3, 4, and 5 being incontinent to loose stools, normal stools, or totally incontinent. So even with this procedure, patients with high anorectal malformations had poor outcomes. Additional problems that may be seen in patients with high anorectal malformations are urinary tract problems, fertility, and sexual dysfunction. I'm not going to go into any of those except to mention them, as they do sometimes cause ongoing lifelong problems for these patients. Unfortunately, there's just not very much data on these in terms of the outcomes into adulthood and what the true rates of problems are. So there's still many questions about the outcomes in adults and whether they reach a plateau and then deteriorate, or whether that's just one study where that seemed to be the case. Who the best practitioners are to care for these patients. So in the pediatric surgery world, most of these patients stay under the care of their pediatric surgeons, even though the issues being dealt with are often not surgical. And many adult colleagues have said to me, well, this really is more of a gastrointestinal GI doctor issue, not a surgical issue. Why would they go on to see an adult colorectal surgeon? And I think that's a question that bears discussion, and certainly it takes, I think, some surgeons to understand the complex issues these patients have gone through, but probably they are best served at some of the complex specialty care clinics that involve both surgeons and gastroenterologists in terms of dealing with their ongoing lifelong issues.
Thank you, Dr. Henry. Does anybody have any questions they'd like to bring to the floor?
I have the patient in her late 20s, lots of congenital anomalies. You already know she has her transverse colon in her chest.
Yes.
She had an anorectal malformation also, actually, I think, in peripheral anus, and now is getting a little mucosal prolapse. Like, she doesn't really have a sphincter. She irrigates every day, but she has a little mucosal prolapse that's in her perineum that's bothering her.
So you want to know about managing the prolapse?
Apparently, when she was younger, probably before age 10, she almost had complete prolapse, and they actually redid it. They pulled out some mucosa and resutured her, but she really doesn't look like she has a lot of room to do anything there. Any advice?
I'll open it to any of my other speakers, and then I'll give you my best shot. Anyone else want to take it?
You said she does irrigations. Does she do antegrade enemas, or she does?
She does mostly antegrade, although it's from kind of a mid portion of what's left of her colon. She intermittently has to do perineal enemas because she can't get her catheter in. And then she'll show up and we'll get the catheter in. She'll leave it in for a few days, and then she does okay for 3, 6, 12 months, whatever. But this newer recurrent mucosal prolapse has her a little bit concerned.
And she's able to, she keeps pretty empty. She's not straining with that regimen
yeah, she
or
does great.
anything. Yeah.
Has she had a contrast enema?
Not recently, probably.
So I'd probably start with that and see what the degree of redundancy is. One option might be actually just to do a mucosal resection and do a reanastomosis, ensuring that you stay above the dentate line.
She has no dentate line.
She has no dentate. She was in perforated anus, not a Hirschsprung kind of thing. Yeah.
Right, no dentate line.
So you could redo that, and it probably would have very little consequence. You have a small risk of breakdown, but that would, if there was a significant amount of redundant bowel right above that area, that's probably what I would do. Your alternative would be something like a Thiersch wire. An internal wire that can be sewn through there. So if there's not redundancy, that may be something that helps the prolapse. There also have been some work done on injecting a sclerosant to try and minimize prolapse. It's a unique enough problem that it's probably one I would talk to a specific pediatric colorectal surgeon about before I made any incisions on it, but I would start with a contrast enema to get an idea of the degree of redundancy or where your problem lies. What center are you at again? I don't remember.
I'm in Albany, New York.
You're in New York. Who's the best New York guy?
It could be someone
gal?
actually in the city at this point, in New York City too, at this point.
Yeah.
Yeah, I think she's originally an patient of Penya's. Yeah. Okay. I will say it's interesting that you guys give your patients up at 18. You know, the pediatricians keep them till they graduate from college.
Yeah.
There's a lot of regional variation, I think, there.
Thank you.
Thank you. Thank you, everyone. We appreciate you being here. Please keep in mind, Stages of 2018 is in Seattle, Washington. It is combined with IPEG, so there will be a large amount of pediatric material in that conference, and we very much hope to see you there. Have a great day.